Hello, good morning, good afternoon, good evening, good night, wherever you are. In this video, we are going to demonstrate how to conduct medical surgical assessment. So we are going to demonstrate, and in our case here, we have Mr. T with cellulitis and diabetes admitted at XY Hospital. The characters in this video will be the lecturer from the university, the co-assessor from the ward, the student nurse, and our patient, of course, Mr. T. So welcome to this video. Good morning, sir. Good morning, madam. Welcome to XY Hospital. This is the male medical ward. My name is Student N, and I'm a student from the University of XY in Kenya, ready for medical surgical assessment. I will start by orienting you to the ward before we focus on my patient for the assessment. At the entrance of this ward, you can see we have a fire assembly point. This fire assembly point is clearly marked as per the safety protocol. So in case of any emergency, say fire, all the staff, all the patients, and the visitors must report there. We also have fire extinguishers positioned at both the entrance, exit, and also other strategic points in the ward, and this is normally for quick response in case of fire. Moving inside the ward, this is the male medical ward, and it has a capacity of 25 beds. We care for patients with medical conditions such as cellulitis in diabetes. We also have malaria cases, hypertension, peptic ulcer disease, respiratory infections like pneumonia, TB, cystic fibrosis, etc. You can be able to see our top 10 conditions. These are some of the conditions that we normally focus on in our ward. Moving further inside, you can be able to see the nurse station, and it's located here. So from this point, we manage all the patient care activities and maintain key records. And this includes records like the MOH 301 inpatient register for recording admission details. We also have the admission and discharge list to monitor patient flow, the incidence book for reporting unusual events. Also have the doctor's ward round, the emergency tray register, inventory register, antibiotic register, and so many other records based on the needs. So like the MOH 301, this is the inpatient register. It is used for recording admission details. So once we admit a patient, we are going to fill the details in this MOH 301. And on the day of discharge, we have also to fill the details in this register. And you can see the different columns that are here. Next, we have the admission and discharge list. This is just to monitor the patient flow. So in a quick glance, you can be able to tell how many admissions have you had today, how many discharges have you had also. We had talked of the incidence book. In our case here, it's the incidence book. In some areas, this record can be referred to as the occurrence book or the adverse event register. Just as we had indicated, it's used to report unusual events involving patients, staff, visitors, equipment, environment within the hospital. So there are some rules that you're supposed to adhere to. So number one, you need to record all the incidents immediately they happen or at the end of your shift. When recording, you need to be factual, you need to be objective, you need to be specific, you need to avoid blame language. You only report serious incidents to supervisors and complete a formal incidents report form if required. Throughout this one, you ensure confidentiality and you store the incidents book securely. So some of the unusual events that you can record, starting with the patient related events, like if a patient falls or there's an injury within the ward, medication error, patient absconding or living against medical advice, sudden deterioration or unexpected death, pressure sores or ulcers acquired in the ward, also patient to patient or patient to staff aggression can also be recorded in this part. Staff related events include things like needle stick or sharp injury, assault, staff collapse or illness while on duty or breach of duty or professional misconduct. Equipment, environment or security incidents, infection control breaches, all are recorded in the incidents book. The next is the emergency tray register. You can be able to see that. In other sectors, it's referred to as crash cut register. So some of the common drugs that we need to find here is adrenaline, used for anaphylaxis or in cardiac arrest, atropine sulfate, used for patients who are bradycardic, sodium bicarbonate, used in patients who have metabolic acidosis or experiencing cardiac arrest. We also have glucose 50%, diazepam, hydrocortisone, albuterol for nebulization, lidocaine, naloxone, and the Lasix. Those are some of the drugs that you'll find there. The inventory register. The inventory register is used to track the equipment in the ward. So we record the date of entry, item description, opening balance, stock received, and this one has to be handed over to every nurse as they end the shift. On the nurse station also you can be able to see a computer. So we have a computer system where nurses normally log in using personal usernames and passwords to order medications from the pharmacy department. Also to request non-farms from the hospital store. Thank God we have a porter here. So once the order has been done and it's ready, a porter is normally sent to collect those ordered items, and it's the role of the nurse to counter check and ensure that they are the right items that they ordered, either from the pharmacy or the stores. Moving to this waste segregation area, here we normally observe the 3-bin waste management system. So we have the yellow bin, which is used for infectious wastes like used gloves, dressings. Then we have the black bin, which is used for general non-infectious wastes like paper, packaging, food remains. And lastly, we have the red bin for anatomical waste. Although this is very rare in this world, except during wound debridement, certain dressings involving tissues called sloughs or removal of necrotic tissue, and this is where we place them in this red bin. Far through it, you can be able to see the sharp box. We can refer to it as sharp box, or some people refer to it as sharp container. This one is normally used for disposing needles and sharp objects, right? So you'll be able to see the ampules and the sharps being placed in this. Remember to know when it's full, so you can be able to see the mark that shows full is at that level, and that is for our own safety. Moving on to the decontamination area. So here we also have the 3 containers. The first one is the jig container, the sodium hypochlorite. So this is for disinfection of reusable equipment. We have several equipments in this wood that we normally disinfect. Soaking time is usually 10 minutes, the standard, but the ranges is 10 to 15 minutes per the different studies that have been conducted. But before you use jig, you have to reconstitute as per manufacturer strength. And always add jig first in the container, then add water on top, because this normally prevents chlorine evaporation. Always replace this solution after every 24 hours and ensure all the equipments are fully submerged. Once you're done with the 10 minutes, you move this equipment to the soapy water, and the main purpose here is to remove the jig residue. So you transfer these equipments to this soapy water bucket. You use a soft brush to scrub equipment gently to remove any dirt or jig residue, and then ensure full submission of the equipment. So use of fresh soapy water prepared at the start of each shift should be our guide there. Then you can change the soapy water when visibly dirty or after 24 hours. After washing, you rinse the equipment with clean running water, all right, before you can be able now to dry them. You dry them, you inspect so that you could check if there's any damage, dust or retained dirty. You also now package them, and now you can send them to the Central Sterile Service Department for autoclaving or just sterilization generally. Moving further deep to the ward, you can be able now to see our ward is organized into 3 patient care sections. We have this acute room, which is closest to the nursing station, and this is for patients requiring close monitoring, like those with severe cellulitis in DEM, those with diabetic ketoacidosis or the sepsis. Further, you have now the subacute area, and you can see the subacute area is for patients who are recovering but are still having still require moderate monitoring. For example, controlled cellulitis cases or post-malaria cases will be in this section. Then the farthest is the stable or the discharge room. So this is normally located farthest away from the nurse station and is for patients who are awaiting discharges, such as those who have healed of cellulitis or stable diabetes. Next, we also have the emergency tray. You can see the emergency trolley here. It is positioned in that designated corner with fully stocked for emergencies, and we had mentioned the drugs. We also have the oxygen source. So remember, masks are also disinfected by the CDEX in that corner. Laboratory sample collection is managed through the main corridor near that ward. Then with that, I'm now ready. I can now introduce my client. That was all about orientation. Is that okay, sir, madam? Yes, you can proceed. Thank you so much for that confirmation. Now I'll start by introducing my patient. So let's approach my patient. My patient is on this bed. Yes. So good morning, Mr. T. Yes, my name is student N. Thomas, and I'm here today with my assessors. We would like to carry out a clinical assessment as part of my training. The assessment will involve asking you a few questions, performing physical examination on you, and explaining your case to my assessors. We will ensure that your privacy and confidentiality is adhered to. Do I have your consent to proceed? Yes, you may proceed. Okay, thank you. I'll go ahead and now screen. Yes, okay, just pull this, pull that. Okay, I've been able to screen. And thank you, sir. Thank you, madam. Let me now present Mr. T's case. So Mr. T is a 55-year-old African male, married, residing in Narok town. He's a small-scale farmer by occupation. Upon admission, he was assigned inpatient number and he was allocated this bed number 3 in this acute room of the male medical ward due to the severity of his condition. So present, he's still in acute care section. So we have not transferred him to the subacute or the discharge room. His details have been captured in the MOH 301 inpatient register, nursing records, medical chart, and laboratory request forms. History of presenting illness for Mr. T. Mr. T was admitted on 9th July 2025 through the emergency department. He presented with painful swelling of the right lower leg lasting for 4 days that was associated with redness, warmth, fever, and general body weakness. He had difficulty in walking due to the swelling and pain, and also Mr. T presented with loss of appetite, feeling generally unwell. The past medical history for Mr. T is a non-type 2 DM for the last 5 years and is on metformin 500 milligrams twice daily. He reports poor glycemic control with inconsistent follow-up. Social history, Mr. T is a non-smoker and he does occasional alcohol intake. Economic history, he is a low income earner depending on small scale farming. What was the admission and the entry point? Mr. T was admitted via the emergency department. His condition met the hospital's admission criteria for cellulitis in diabetic patient. At that point, he had elevated random blood sugar of 17.5 milliosmoles per liter. He had extensive swelling with risk of infection spread, and there was also fever and sign of systemic infection. So Mr. T was admitted and put on initial treatments including IV normosaline 500 mils. We also had IV ceftriaxone 1 gram start and paracetamol 1 gram per oral start. Blood sugar monitoring was initiated. He was then admitted to this male medical ward. While in this ward, Mr. T has undergone several investigations. We have RBS on admission was 17.5 milliosmoles, but currently the RBS is 14.8, so some improvement to some extent. CBC, complete blood count, you find that it was generally okay, except for the white blood cell, which was about 14,000 cube, indicating that there is likely to have an infection. Wound swab for culture, the sample was taken, but results are still pending. We are still waiting for the results. And then MPS, malaria parasites, it was negative for the malaria parasites. So we have ruled out malaria. So currently, the treatment, Mr. T is still on IV ceftriaxone 1 gram twice daily. As you know, that ceftriaxone is a broad spectrum antibiotics that belongs to the class cephalosporin, and it's used to treat bacterial infections including skin and soft tissue infection like cellulitis. Cellulitis is a bacterial infection of the skin layers. Therefore, ceftriaxone helps eliminate that causative bacteria. Ceftriaxone is normally given IV. We are giving it IV, and this ensures faster absorption, and it improves its effectiveness in this acute infection. The second drug that Mr. T is on is IV metronidazole 500 milligrams 3 times daily. Metronidazole is antibiotics specifically targeting anaerobic bacteria and protozoa. Cellulitis in diabetic patients often involves mixed infection. We have both aerobic and anaerobic bacteria causing the cellulitis. For that reason, metronidazole complements ceftriaxone by covering the anaerobic pathogen. In this case, we are giving Mr. T metronidazole via intravenous route, and this is appropriate for serious infection needing hospital care. The third drug is metformin. Metformin 500 milligrams twice daily. So oral hypoglycemic agent, or in the biguanide class, used for managing type 2 diabetes. So why is it here? Mr. T is a non-diabetic patient. So good glycemic control is essential in promoting wound healing and preventing infection spread. In our case here, we are giving metformin per oral. Then we have IV normosaline, 500 ml every 4 hours. As we all know, fluid therapy is essential in maintaining hydration, electrolyte balance, and also supporting circulation. So normosaline is used in our case here because infections and fever normally increases fluid loss and demand. So normosaline helps restore fluid balance and is used as a vehicle for some IV drugs. In our case here, we are giving it intravenously. So in our case, for over 4 hours, we are using continuous, but sometimes it can be intermittent. But of our case, it's for continuous for the 4 hours. For the 4 hours, right? So we are using a micro drip set, the 20 drops per milliliter. So the infusion rate, to calculate the infusion rate, you normally take the total volume, which is 500, times the drop factor, which is 20, divide the time in minutes, so which is 4 hours divided by 60 minutes. And that gives us 42 drops per minute. So when setting out our infusion will be having the 42 drops per minute. So this normosaline was going to run over 4 hours using a macro drip set, 20 drops per mil, and that will gives us 42 drops per minute. The last drug we have paracetamol per oral. This is an antipyretic So it's fever reducing and analgesics, pain relieving medication. So this is going to help Mr. T manage the fever and the pain associated with the cellulitis. The other non-pharmacological management involves the wound care. So this is an independent action by the nurse. So you're going to do daily wound care using the sterile technique, and this the objective is to prevent infection, promote healing, and remove exudate or necrotic tissue. So we'll perform hand hygiene before and after this procedure. We'll prepare the dressing materials, sterile gloves, sterile gauze, antiseptic solution like the normal saline and the povidone iodine, the tape, the forceps, the dressing pack. Thereafter, expose the wound site while ensuring the patient privacy. Clean from the center to the outside of the wound. Then apply the sterile gauze and secure with tape or bandage. Another nurse independent action is elevation. Apart from the wound dressing, elevation of the affected leg in order to reduce swelling, improve venous return, and minimize pain. So we are going to elevate the leg slightly above the heart level using a pillow or a foam support. Then we ensure that the patient is comfortable and the leg is well supported. So with the leg elevated, circulation, sensation, and skin color will be assessed every 2 to 4 hours in acute cases, and at least every 6 to 8 hours once the patient stabilizes. So this will help detect any signs of compromised blood flow or worsening infection. Furthermore, we are going to encourage Mr. T to limit unnecessary movement until swelling has subsided. We'll continue with monitoring. So blood sugar monitoring will be done after every 6 hours. So vital signs will be done every 4 hours. So for our case here today, Mr. T complained of pain at the wound site, general body weakness, and loss of appetite. That made me to come up with the 3 nursing diagnoses based on his complaints. Number 1 is acute pain related to inflammation in the right lower limb as evidenced by the patient report of pain and tenderness. Another one is risk for infection spread related to cellulitis and diabetes mellitus. And lastly, impaired physical mobility related to swelling and pain in the lower limb. I'll now show you the nursing care. Yes, you can be able to see the nursing care, how I've been able to manage. Yes, sir. Yes, madam. Please proceed. Okay, thank you. So now I'll focus physical examination. So I'm going to demonstrate the hand hygiene first and then ensure also the privacy. I can see my patient is alert, lying in the bed with the right leg elevated. He appears weak, but not in acute distress. Looking at the vital signs, can be able to see the temperature, the 38.2 degrees Celsius, pulse 98 beats per minute, blood pressure, respiratory rate, random blood sugar. Can be able to see the blood pressure is 135/85 millimeters of mercury. Inspection of this affected limb. This right lower limb is visibly swollen with mid calf to angle, that is from the mid calf to the ankle. The skin appears red, shiny, and stretched. There is no open wound or discharge observed. On palpation over the affected area, it is tender on palpation. No crepitus have been felt. But generally, the chest is clear. Sounds are bilateral. Abdomen is soft and tender. Extremities, there is no edema beyond the cellulitis site. Okay, thank you. One question. Why is cellulitis in diabetic patient a high priority admission? Thank you, sir. Cellulitis is in diabetic patients is a high priority because diabetes compromises the immune response. It also delays wound healing and increases the risk of complications such as abscess formation, gangrene, or sepsis. Okay, well answered. Please proceed with the documentation in the nursing notes, care plan, and patient progress records. Thank you so much. Thank you so much for this comprehensive demonstration of clinical assessment in the medical surgical unit, focusing on the patient with cellulitis. So remember the key steps for your clinical assessment in the medical ward. You need to orient the assessors. You need to introduce the patient and obtain consent to go ahead with the assessment from the patient. Then present the case clearly, highlighting the patient history, admission details, investigation, current management, and patient complaints. Then, after you perform a focused examination confidently while ensuring privacy and safety, then you state at least 3 clear nursing diagnoses based on the patient's findings. Then lastly, ensure full documentation in the patient's records and the MOH registers. So good luck with your clinical assessment. Please subscribe to this channel for more nursing education and the tutorials.